Bismillahirrahmanirrahim. Today I am going to discuss micturition reflex, physiological anatomy, nervous connection of the urinary bladder, and the cystogram. Lesson contents are micturition, physiological anatomy of the urinary bladder, nervous connection of the urinary bladder, transport of urine to the urinary bladder, and micturition reflex. Functional anatomy of the urinary bladder. Before going to the micturition reflex, I will briefly discuss the anatomy of urinary bladder. The urinary bladder is a smooth muscle chamber composed of two main parts. One is the body, which is the major part of the bladder in which urine collects, and the neck, which is a funnel-shaped extension of the body connecting with the urethra. Posterior urethra. The lower part of the bladder neck is also called the posterior urethra because of its relation to the urethra. Here you can see the urethra are located anteriorly and the urethra is located posteriorly. That's why it is called the posterior urethra. Shape of the bladder. The appearance of the bladder vary depend on the amount of urine stored. When full, it exhibits an oval shape, and when empty, it is flattened by the overlying bowels. The trigone. On the posterior wall of the bladder is a small triangular area called a trigone. At the lowest apex of the trigone, the bladder neck opens into the posterior urethra, and the two ureter enter the bladder at the uppermost angle of the trigone. The trigone inner lining is smooth. The remaining bladder muscle is folded to form rugae. This portion of the bladder is smooth and the remaining wall of the bladder is rugae. That's why it can be differentiated from the remaining muscle of the urinary bladder by its smooth appearance. Each ureter, as it enters the bladder, courses obliquely through the detrusor muscle and then pass another 1 to 2 cm beneath the bladder mucosa before empty into the bladder. The ureter pass in the detrusor muscle or in the muscle of the urinary bladder obliquely, and then it enters to the urinary bladder passing beneath the mucosal lining of the urinary bladder. This passage of the urethra through the detrusor muscle produces an physiological valve. When the urinary bladder is empty, the ureter is open and the urine from the kidney through ureter enter into the bladder. And when the bladder contracts, cause closing of the ureter and prevent retrograde flow of urine from the urinary bladder into the ureter and back to the kidney. In this way, prevent or produce pressure in the ureter and pelvis of the kidney. The smooth muscle of the bladder is called the detrusor muscle. The urinary bladder is made of smooth muscle, and this muscle is called detrusor muscle. When contracted, increase the pressure in the bladder up to 40 to 60 mm. When this muscle contracts, it increases the intravesicular pressure up to 40 or 60 mm of mercury. Thus, contraction of the detrusor muscle is a major step in emptying the bladder. Detrusor muscle fuse with one another. Electrical pathway exists from one muscle cell to the other. As we know that in smooth muscle we have gap junction, and here also this muscle is made of smooth muscle, detrusor muscle. They have loose connection between each other, and the electric potential pass easily from one muscle fiber to the other through these gap junctions. Therefore, an action potential can spread throughout the detrusor muscle from one muscle cell to the next to cause contraction of the entire bladder at once, like a sensation. When one muscle fiber is activated, the whole bladder goes into contraction, and this mechanism is called sensation. The bladder neck posterior urethra. As we know that the bladder neck is also called posterior urethra, is 2 to 3 centimeter long, and its wall is composed of detrusor muscle interlaced with a large amount of elastic tissue. The muscle in this area is called the internal sphincter. Its natural tone normally keeps the bladder neck and posterior urethra empty of urine and therefore prevent emptying of the bladder until the pressure in the main part of the bladder rises above a critical threshold. Beyond the posterior urethra, a layer of muscle called the external sphincter of the bladder. This muscle is a voluntary skeletal muscle. The external sphincter muscle is under voluntary control of the nervous system and can be used to consciously prevent urination even when involuntary control or attempt to empty the bladder. Nerve supply of the bladder. The urinary bladder is supplied by somatic nervous system, and these fibers originated from the sacral S2 and S4 and by autonomic nervous system, parasympathetic and sympathetic. The parasympathetic roots originate from S2 sacral plexus and S4, and the sympathetic roots arise from T11 to T12. The sympathetic nervous system causes relaxation of the bladder and constriction of the neck of the bladder. And the parasympathetic nervous system relaxes the whole urinary bladder. The somatic supply is by it is a motor nerve, somatic motor nerve, and it is through pudendal nerve, and it causes relaxation or constriction of the external urethra. This is the clear diagram. Here the sympathetic supply to the bladder originate from the thoracolumbar region, bypass sympathetic chain ganglia, and they synapse in the hypogastric ganglia, and from there two fibers originate. One type of fiber supply the body of the bladder and the other supply the neck. The same is from the sacral region. These fibers originate from S2 and S3, S4, and they synapse in the pelvic ganglia. From here, a second order or postganglionic neuron originate and also supply the bladder, body, and the neck. And the somatic control is through pudendal nerve. A somatic nerve they also arise from the S2, S3, and S4 region of the sacrum, and they supply the external sphincter. The pelvic nerve carry parasympathetic fiber to the bladder. In the wall of the bladder, in the detrusor muscle, there are receptors present on the surface of the bladder. The parasympathetic nervous system nerve fiber release acetylcholine, and for this the receptor are muscarinic receptor or M3 receptor, which contract the bladder or has positive effect on the bladder. The sympathetic nervous system also have receptor on the bladder wall and in the neck. On the bladder body there are beta 3 receptor, and in the neck or internal sphincter the receptor are alpha 1. And the neurotransmitter released by the sympathetic nervous system is noradrenaline. Body of the bladder, they have negative effect and relax the bladder, and on the internal sphincter, on the alpha receptor, it causes constriction of the internal urethra. The pudendal nerve release, which originate from the sacral plexus and carry somatic fiber to the external urethra, they release acetylcholine. And the receptor are nicotinic receptor in nature, and when acetylcholine act on this, it causes positive action which constrict the external sphincter. This sphincter is also under control of the higher center. This is also voluntarily controlled by the higher center. So here both negative and positive effect can be noticed in the external sphincter. This is a more clear diagram from the thoracolumbar plexus. The sympathetic supply, it is the sympathetic supply or sympathetic route to the body and to the neck. On the body is beta 3 and in the neck or internal sphincter is the alpha 1 receptor and here is beta 3 receptor. It relaxes the bladder and here it contracts the bladder. Parasympathetic supply is from the S2 S4. On the wall the receptors are M3. Here they cause contraction of the bladder and they release acetylcholine which act on the muscarinic receptor and contract the bladder. And the pudendal nerve has somatic supply, both positive and negative response. Stages of micturition. Micturition is carried out in 2 stages. Storage stage, voiding stage or micturition stage. Simplified stages of normal micturition. Storage stage. The sympathetic nerve suppress bladder contraction and increase tone in the bladder neck and internal sphincter via the hypogastric nerve. As we know that urine is formed in the kidney. When it comes into the pelvis, it causes stretching of the pelvis and due to stretching the pelvis of the kidney contract and push the urine down in the urethra and this urine enter into the urinary bladder and when the volume increase it causes stretching of the urinary bladder and this supply is by hypogastric nerve. From the thoracolumbar plexus the supply is through by hypogastric nerve which has beta 3 and alpha 1 receptor. Urine is transported into the bladder by the urethra resulting in increased pressure within the bladder. Stretch receptor in the bladder send signal via afferent fiber to the pelvic nerve to the sacral cord. Reflexes from the bladder are sent to the sacral cord which then send signal via the pudendal nerve to contract the external urethral sphincter, maintain urinary continence. From here sensory reflexes are sent here, then through pudendal nerve the impulses by parasympathetic nerve are sent to the neck and the neck is contracted and prevent escape of urine from the urinary bladder. Micturition reflex occur in 2 steps. In step 1, micturition contraction are the result of a stretch reflex. The sensory receptor in the posterior urethra, when this area being filled with urine, pressure in the bladder is increased, so micturition reflex originate or started. And the second step is sensory signal from the bladder stretch receptor are conducted to the sacral segment through the pelvic nerve and then reflexively back again to the bladder through the parasympathetic nerve fiber by way of these neurons. From here stretch receptor, when the bladder is stretched from the neck and from the body, signals are sent to the sacral plexus and back by parasympathetic nervous system to the bladder. If the impulse is not so strong, so it causes contraction of the internal sphincter and prevent escape of urine from the urinary bladder, and this supply is secondary signal from the bladder, empty bladder. When the bladder is only partially filled, these micturition contractions usually relax spontaneously. After a fraction of a minute, the detrusor muscles stop contraction and pressure fall back to the baseline. And there is less urine in the bladder. Sensation are sent to the sacral plexus and by the hypogastric plexus sympathetic supply to the bladder, so the bladder wall is relaxed and the neck is contracted when the bladder is empty. In case of full bladder, greater contraction of the detrusor muscle. When the bladder filled more and more, it caused more and more stretch, and this stretch reflex increases and sent to the sacral plexus, and vague impulses cause contraction of the urinary bladder. Once a micturition reflex begins, it is self-generative. Then after a few seconds to more than a minute, the self-generative reflex begins to fatigue and the regenerative cycle of the micturition reflex ceases, permitting the bladder to relax. The micturition reflex is a single complex cycle. Progressive and rapid increase of the sustained pressure and the return of pressure to basal tone of the bladder. In this case, when the urine is not passed, micturition reflex occur again and again in these three patterns. As the bladder becomes more and more filled, micturition reflex occur more and more often and more powerful. The micturition reflex is an autonomic spinal cord reflex, but it can be inhibited or facilitated by the center in the brain. These centers include strong facilitative and inhibitory center in the brainstem located mainly in the pons, and several centers located in the cerebral cortex that are mainly inhibitory but can become excitatory. Voiding stage: when the bladder stretch reaches the micturition threshold, apparent bladder signal cause the sacral segment to stimulate the pontine micturition center. When the bladder is full, more intensive impulses are sent to the sacral plexus, and from the sacral plexus they are directly passed to the pons and the higher centers. Sensation of fullness and pain are evaluated by the higher cerebral center. This pressure and pain sensation are evaluated in the higher centers. Cerebral centers initiate toilet seeking. When toilet is deemed appropriate, the pontine micturition center signal to suppress the sacral reflex, which relax the internal sphincter, relax the external sphincter, activate parasympathetic fiber of the pelvic nerve, causing contraction of the bladder muscle and the relaxation of the internal sphincter. In this way, urine is ejected from the body. This is a short summary. When the stretch receptor detect filling of the bladder, transmit apparent signals to the spinal cord. Signal return to the bladder from spinal cord segment S2 and S3 via parasympathetic fiber in pelvic nerve. Efferent signal excite detrusor muscle. Efferent signal relax internal urethral sphincter. Urine is involuntarily voided if not inhibited by the brain. Voluntary control. For voluntary control, micturition center in pons receive signal from stretch receptors. If it is timely to urinate, pons return signal to spinal interneurons that excite detrusor and relax internal urethral sphincter. Urine is voided. If it is untimely to urinate, signal from the cerebrum excites spinal interneuron that keep external urethral sphincter contracted. Urine is retained in the bladder. If it is timely to urinate, signal from the cerebrum inhibit sacral neuron that keep external sphincter closed. External urethral sphincter relax and urine is voided. The cystogram. When there is no urine in the bladder, the intravesicular pressure is about 0. This is the pressure column and this is the volume. When there is no volume, the pressure is 0. But by the time 30 to 50 milliliter of urine has collected, the pressure rises 5 to 10 centimeter of water. Additional urine 200 to 300 milliliter can collect with only a small additional rise in the pressure. This constant level of pressure is caused by intrinsic tone of the bladder wall itself. From 50 to 300 mm of urine, there is no change in the intravesicular pressure or very small change. You can see that the pressure at 50 ml is 5/10 and also on 300 ml is 10 milliliter of water. Beyond 300 to 400 milliliter, collection of more urine in the bladder causes the pressure to rise rapidly. When this volume increase beyond 300 millimeter, there is a sudden rise in the vesicular pressure, and the pressure rise rapidly. Superimpose on the tonic pressure change during filling of the bladder or periodic acute increase in pressure that lasts from a few seconds to more than a minute. The pressure peak may rise only a few centimeters of water or may rise to more than 100 centimeters of water. These pressure peaks are called micturition wave in the cystogram and are caused by the micturition reflex. These are the peaks of pressure peaks in the cystogram and they are called cystogram wave, micturition waves. When the bladder is only partially filled, the micturition contraction usually relax spontaneously after a fraction of a minute. The detrusor muscles stop contraction and pressure fall back to the baseline. The volume is less than 400 or 300, there is micturition reflex, but they spontaneously subsided. As the bladder continues to fill, the micturition reflex become more frequent and cause greater contraction of the detrusor muscle. Beyond the 400 or 300 ml, there is sudden or step rise in the intravesicular pressure. So in cystogram, these pressure waves occur in 3 phases. When they're in phase 1 or 1A, an increase in intravesicular pressure is 0 to 10. When the volume is 0 to 10 centimeter of water, at initial increase in volume from 0 to 50 ml. When there is increase of volume from 0 to 30 or 50 ml, there is increase of 10 centimeter of water in the intravesicular pressure. In stage 2, 1B, filling of the bladder from 50 to 400 ml of urine caused no significant increase in intravesicular pressure. You can see that this is remain the same from 50 to 400 ml or 300 ml. And in stage 3, when volume exceeds 400 ml, will cause a step increase in intravesicular, triggering the micturition reflex. Beyond 400 ml, there is a step increase in the pressure and which trigger the micturition reflex. Bladder sensation at different urine volume. Urine volume of 150 to 300 ml, first urge to wait. From 300 to 400 ml, sense of bladder fullness. When the volume is from 400 to 600, person start feeling sense of discomfort. From 600 to 700, in this case, sense of pain starts. Micturition reflex start to appear at the first stage and progressively increase in intensity as the volume increase. Micturition reflexes can be voluntarily suppressed. At 700 ml, it is the break point and micturition cannot be suppressed and there is dribbling of urine. This when the bladder reach to this volume, a maximum pressure is produced and escape of urine or dribbling of urine occur. As a routine, I have added these 2 MCQs. Reply your answer in the comment box. So thank you. See you in the next lecture.